In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life. perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
It is my pleasure to welcome all viewers and participants to the EGSSA webinar. After the foundation of the Egyptian Shoulder Society, we launched a monthly webinar addressing basic and advanced topics on different shoulder surgery subjects. We have used the platform to connect specialists from all over the world to continue scientific collaboration during the coronavirus pandemic and beyond. The community we have built includes more than 1,000 viewers from over 100 countries for each of the 7 webinars. Today, we celebrate the success by hosting the 8th webinar on anatomic and reverse total shoulder replacement. Many considerations in implantation of a total shoulder have to be taken into account, especially the head height, width, retroversion, valgus angulation of the head, also offset of the center of the shaft to the center of the head, the shaft width and glenoid height and width, and the backs of cancellous bone in the glenoid version and glenohumeral offset. A planning using these measurements is done in our clinic by making a CT scan and 3D scan of both the damaged and the sound shoulder. The aim is to have a guide measurements of the implant based on the sound shoulder in order to get the best anatomical reconstruction of the humeral head and glenoid of the damaged one. Drs. Hassan and Dr. Hani will talk about the anatomical total shoulder replacement, and Dr. Oliver will talk about the glenoid retroversion and the limitation of the anatomic total shoulder replacement. Also, using the CT scan, we can use PSI guide instrument for preparation of the head and glenoid. As well, will be discussed by Dr. Mahmoud and reference to the PCI application in total shoulder replacement. For all fracture cases treated with arthroscopy or an arthroplasty, a PSI model is made for surgical planning and orientation during the surgery. The reverse total shoulder replacement has different considerations and measurements. This subject will be addressed by Dr. Ahmed and Dr. Ed McFarland. At this point, I would like to congratulate the moderator, Dr. Yasser Al-Safuri, for being appointed the chief of the orthopedic departments of Cairo University Medical School. I would like also to welcome and thank Dr. Hassan, head of orthopedic department, Al-Gala Military Hospital, and our partner, Dr. Ahmed Andil from Shoulder Service in Alexandria University. Also, Dr. Hani Sayed from Al-Faqih University Medical College in Jeddah, Saudi Arabia, and Dr. Mahmoud Hafiz, head of Orthopedic Department, 6 October University, Cairo. A special thank to Dr. Oliver Verboot, head of the Orthopedic and Trauma Society in Belgium, for his 3rd participation in our webinars. Finally, I am very happy to welcome Ed McFarland, head of the Shoulder Service in Johns Hopkins University Medical College. Many thanks to the COB organizing company and our supporter, Pfizer Therapeutics. With great excitement, I would like to hand over to Dr. Yasser Al-Safuri, who will moderate this webinar. Thank you very much.
Thank you very much, Professor. So now we're going to begin our program with the first presentation about anatomical arthroplasty indication and limitation by Dr. Hassan Ali. Go ahead, Dr. Hassan.
First, I have to thank Professor
The voice, could you adjust the voice, Dr. Hassan? Dr. Hassan Ali, the voice is not so clear. The voice is not so clear.
I'm trying to solve the problem. Second. Military medical complex. Voice is clear?
Yes, it's clear.
Yes.
Thank you.
At first, I have to thank Professor Dr. Basim Fliga for his invitation to the 8th webinar, and congratulations, Dr. Basim, for your newly published work. Thanks for Professor Dr. Yasser El-Safuri, and congratulations, Dr. Yasser, for being head of the Orthopedic Department, Faculty of Medicine, Cairo University. Many thanks to all my colleagues. This is our topic overview. When to consider shoulder replacement? When your patient lost joint function and range of motion and experienced significant pain, the quality of his life has been changed, despite non-surgical treatment or joint preserving surgery like synovectomy, arthroscopic debridement. When we spend all conservative measures with no effect, we have to shift to another solution. First, shoulder arthroplasty have been performed at 1893 by Dr. Jules Pa, and then the generations comes after. First generations until the fourth generation was modular, adaptable, adjustable, anatomical, unconstrained for creating normal anatomy with variable inclination and offset. Types of arthroplasty, these are types: resurfacing, bone preserving, but limited indication. Stemmed hemiarthroplasty, lot of indications, mainly trauma patient. Total shoulder arthroplasty, our topic, and reverse total shoulder arthroplasty. Anatomic total shoulder means prosthesis that recreate and preserve normal anatomy of the glenohumeral joint. The humeral head offset, posterior displaced 2 to 4 millimeters, and medially displaced from 7 to 9 millimeters. Glenoid has superior and inferior width, height from superior to inferior, version from 2 to 9 degrees retroversion, and 4 degrees inclination superiorly. These two lines, important line for arthroplasty, FH line, the cricoid to the lateral border aspect of the greater tuberosity, what's called lateral humeral offset, and EF, vertical distance between humeral head and the greater tuberosity, equal 8 millimeter. Indication for anatomic total shoulder arthroplasty. The main indication of anatomic total shoulder arthroplasty is primary osteoarthritis of the glenohumeral joint, arthritic degenerative inflammatory conditions of the joint with an intact or repairable rotator cuff. Pathology of the osteoarthritis joint: subchondral sclerosis, cysts, goat's beard, pathognomonic of advanced osteoarthritis, narrowing of the joint space, but subacromial space still exists. Posterior glenoid erosion, progressive loss of the external rotation, posterior head subluxation, biconcave glenoid, and to a lesser extent, rotator cuff tear. Pathology of the rheumatoid arthritis, the other indication: marginal erosion of the humeral head, medialization of the humeral head, center glenoid wear, a high rate of rotator cuff tears, bone softening, narrowing of the joint space, but few osteophytes. Secondary osteoarthritis, instability, aggressively treated or neglected, sequelae of humeral head, osteonecrosis, failed partial joint replacement. Other degenerative conditions like gouty arthritis, post-traumatic, as locked posterior fracture dislocation or post-surgery. Why do shoulder replacement fail? Because improper patient or improper prosthesis or bad decision. Pre-operative, operative, and post-operative causes. These are our limitations. Limitations related to the patient, like bad general condition, unreliable patient, neurological conditions, history of infection or septic focus, improper choice of the operation, as in young and active patient with a glenohumeral osteoarthritis. We have to consider the alternative, biological grafting. If failed, we have to try rim and run, because total shoulder arthroplasty in such categories has unreliable long-term results. Operative. Glenoid loosening, the most common cause of failure of total shoulder arthroplasty. Failure to restore normal function. If glenoid implant retroverted more than 10 degrees, or superior inclination more than 10 degrees, or glenoid seating less than 80%. Biconcave glenoid, B2 or C, according to Walsh classification. Glenoid dysplasia or hypoplasia. In mild cases of glenoid retroversion between 10 to 15 degrees, consider eccentric reaming, but keep in mind that the sclerotic subchondral bone resists prosthetic head stresses. In severe cases, we could consider bone grafting and augmentation of the glenoid, and there is a debate about this point. The glenoid component, select proper glenoid size to avoid abutment against lesser tuberosity and the anatomical neck. A small component, it leads to eccentric loading and resulting in loosening and failure. Large component induce overstuffing of the joint due to limited range of motion and failure. Orientation of the glenoid. Glenoid center line perpendicular to the center of the glenoid fossa, closely aligned with the scapular plane. Stability compromised by glenoid excessive version. So glenoid component should be normalized at the time of the operation. If net humeral joint reaction force is not centered to the glenoid fossa due to muscle imbalance, eccentric loading make a rocking horse loosening of the glenoid component, and also mismatch of the glenoid and the humeral diameters of the curvatures lead to force malalignment before rim contact occurs. Patient-specific instrumentation was developed as an alternative to navigation system and is valid for shoulder arthroplasty, and Dr. Bassem Fliga talk about this point. Glenoid concavity, glenoid arc determines maximal angles that net humeral joint reaction force can make glenoid center line before dislocation occurs. Our aim is proper glenoid concavity. Glenoid arc damaged by wear and inflammation, and the posterior wear typically in the osteoarthritis, but central erosion in the rheumatoid arthritis. Again, effective arc means balance stability angle and control it. In severe cases with central erosion, glenoid vault less than 15 millimeter, we can consider use of inset glenoid component. Rotator cuff and shoulder muscles, rotator cuff associated with the rotator cuff tear associated with the osteoarthritis from 5 to 10%. If it's small, we can ignore, or it's better to repair during surgery. In case of repairable or massive rotator cuff tear, in case of severe fat infiltration, we can consider the alternative reverse shoulder. Direction of the net HGR force actively controlled by the rotator cuff and other shoulder muscles. If control of the net HGR force compromised by tendon rupture or tuberosity dehiscence, will lead to rotator cuff arthroplasty and consequently instability of the prosthesis and failure. Joint tightness due to arthritis, we have to dissect the contracted capsule anteriorly and cautiously inferiorly and posteriorly as well. And ligaments must be released as well. Posterior head subluxation should be corrected at the operation by anterior capsular release at least. Improper humeral head sizing or positioning have to select a component suitable not to stiffen the joint. Preserve lateral humeral offset to avoid abductor weakness by proper head cut and height. Blocking osteophytes should be removed. Restricted humeroscapular motion interface, and there is normal execution between 3 to 4 centimeters takes place at the upper aspect of the interface between the coracoid muscles and subscapularis. Adhesions of this point, spot welds, between the proximal humerus and cuff on the hand, and the deltoid and coracoacromial on the other hand, can limit the motion of the arthroplasty. And we have to release this point as an early step in the arthroplasty. Humeral articular surface head, anatomically oriented, sufficient should be, because a small part of the sphere compromises stability. Humeral head center line should make neck shaft angle 130 and the retroversion 30 degrees. In case of arthritis, muscle strength compromised due to cuff deterioration, disuse atrophy, previous surgery, or previous injury. We have to enhance strength by balance of the muscles, a tendon repair, tuberosity reattachment, a proper rehabilitation program. That's it. Thank you.
Thank you very much, Hassan Ali, for this very demonstrative presentation. The second presentation will be on reverse arthroplasty indications and limitation by Dr. Ahmed Andil.
Hello, everybody. So my talk will be about reverse shoulder arthroplasty. We all know that the current reverse shoulder arthroplasty that we are using right now was introduced and invented by a French surgeon called Paul Cramont. The first prototype was introduced in 1985, and it was formed of 2/3 sphere with a diameter of 42 millimeters. It was ceramic and cemented. In 1986, the second prototype, and it was 2/3 sphere with a 36 millimeter diameter, and it was metallic and cemented. The definitive one was introduced in 1991. It was half sphere with two diameters, 36 and 42 millimeters. It was metallic and uncemented. Actually, Paul Grammont was not the first one to introduce the concept of reverse shoulder arthroplasty or to reverse the anatomy of the shoulder. Many designs have been introduced by many surgeons and many centers, but unfortunately, they all failed. This is because the center of rotation was still in its position lateral, and that produced lots of stresses that led to glenoid loosening. Also, the method of fixation was not that good, so either loosening of the component happened, dislocation, or even scapular fracture. Grammont noted that, and he just insisted to put the center of rotation more medial and more lateral to reduce the stresses between the glenoids, bone, and the implant. I'm going to talk about something very important, which is notching, and it can be defined as impingement of the polyethylene cup with the lateral pillar of the scapula that results in bone loss, as you can see in the X-ray. It has been well described by a grading system where grade 0, there is no notching. Grade 1, notching occurs along the lateral pillar of the scapula. Grade 2, notching till the inferior screw. And this area, it's an area of controversy because it depends how you put your inferior screw. So if you angle your inferior screw inferiorly, you can reach grade 0 much faster than if you put it in a parallel position. Grade 3, notching goes beyond the inferior screw, and grade 4, it's just reaching the central post. So actually, what causes notching? Classically, it's just due to impingement of the polyethylene cup when we do adduction against the inferior part of the glenoid and the lateral pillar of the column. So when you do adduction, we have abutment of this part of the polyethylene cup with the lateral pillar of the scapula. But Lederman et al. In 2015, they published an interesting paper, and they showed that it's not just a matter of impingements, but also there is friction that happens during rotation, range of motion, external rotation, internal rotation, flexion, and extension, as you can see in this video. Well, notching is not always mechanical. As you can see in this X-ray, notching goes beyond the inferior screw. So if it is mechanical, it should stop at the level of the inferior screw and doesn't go just beyond the inferior screw. So it has a biological aspect. So if we take a sample of this tissue and we look under the scope, we can just see that what we call granulomatous tissue, and there are multinucleated giant cells, polyethylene fragments, macrophages, bone debris, and all that we call it osteolysis. So it's not only mechanical, but it has a biological aspect. Actually, they did a finite element analysis to study the contact between the polyethylene cup and the glenosphere, and they found that contact was higher in the inferior part of the polyethylene cup. So the blue represent the polyethylene cup, and the green area represent the contact between the polyethylene and the glenosphere, and the red area represent the higher stress concentration during range of motion of the reverse shoulder arthroplasty. What about the wear, reverse shoulder wear? We put the reverse shoulder in a wear simulator, and we cycle it in a normal physiologic range of motion. And in this study, they found that the wear was mostly inferiorly. So the inferior part had the most wear. And as regards the retrievals from failed reverse shoulder arthroplasty, Nam et al. Noticed that the notching or the wear occurs mostly in the inferior part of the polyethylene cup. So from all the above, we can say that the contact patch was along the inferior aspect of polyethylene. The maximum stress was also along the inferior aspect of the polyethylene. The maximum wear was also along the inferior aspect of the polyethylene, and notching damage happened there. So this is the part which is very important, the inferior part of the polyethylene. What about the clinical evidence? Actually, there are numerous studies, And numerous studies have shown that there is no difference as regard the constant score in presence of notching. While there are only 2 studies, they have showed that in the presence of notching, the constant score decreased significantly. In another interesting multi-center study that was done in France in many centers, they just studied reverse shoulder arthroplasty done for any etiology between 1993 till 2010, and the follow-up ranged between 5 and 20 years. And they study about 1,035 cases with 5-year follow-up, as you can see. So they found that in less than 10-year follow-up, 16% of the cases had grade 3 or 4 notching. But when the follow-up was over 10 years, the notching was about 29%. So it jumped from 16% to 99%. So it's clearly obvious that scapular notching is progressing. It's not stationary. So from all the above, evolution of the Grumman concept has changed and was a must. So the normal 155 neck shaft angle prosthesis usually had problem of notching, as you can see, and to overcome this, so surgeons just advise we can overcome notching by either doing inferiorization, that means we place the glenosphere more inferior to clear this area of the lateral pillar. Either we put it more inferior or we just use eccentric glenosphere to have a 4 millimeter clearance, as you can see. Another way to overcome that by using a large glenosphere. So usually I put in my cases 42 or 40 size of the glenosphere just to clear this area and to avoid notching. Also lateralization, either you do it like Boileau bio-reverse shoulder arthroplasty, so by lateralizing the glenosphere, you also clear this area, or you can use a metallic lateralized glenosphere. Lastly, the standard is 155 neck shaft angle, but when we are using a 145 degrees or 135 degrees angle, you can clear up this area and prevent abutment of the inferior part of polyethylene cup against the lateral pillar of the scapula. So, to sum up, notching is not just mechanical, but it has biological and biomechanical aspects. We can prevent it by using what we just described. And I think it's better to avoid it because with notching, we just can endanger the glenoid, which is a very important element in the reverse shoulder arthroplasty. As you can see, there are numerous designs as we described, but still further designs are evolving and they are present in the market as stemless or short stem reverse arthroplasty. So actually till now, reverse shoulder arthroplasty is evolving and still evolving till we reach the best arthroplasty to have a better and reasonable outcome for the patient. Thank you for your attention.
Thank you very much, Dr. Andil. The following presentation will be on arthroplasty for proximal humeral fractures by Dr. Hannes Said.
It's my pleasure to be here on the Egyptian Shoulder Society for the second time. My presentation today is about arthroplasty in proximal humeral fractures. I will describe anatomy and classification on brief, and I will describe some tips and tricks in arthroplasty for proximal humeral fractures and some technical consideration and review of literatures. Proximal humeral anatomy is composed of 4 components: the head, the lesser tuberosity, and the greater tuberosity, and the shaft. Inclination of the humeral head is about 1/3 degree, and humeral head has a retroversion from 9 to 40 degree, average from 20 to 25. Establish of proper version is essential for stability and functional outcome. And there's some recommendation about increase the retroversion to decrease anterior shoulder dislocation, but with some cautious, because increased retroversion will affect the tuberosity healing. Blood supply for the proximal humerus is about 64% from posterior circumflex humeral artery, as this paper published on GBGS on 2010 about quantitative assessment of vascularity of proximal humerus on 24 fresh frozen cadaveric shoulder. The mode of trauma, as we know, it's fall on the outstretched hand. The deforming force, the greater tuberosity, go posterior and medial by the ball of supraspinatus and infraspinatus. The lesser tuberosity go anterior and medial by the effect of subscapularis. The shaft is pulled anterior and medial by the effect of pectoralis majors. Near classification is one of the most famous and favorable classification for proximal humeral fractures. Is classifies a fracture into 1 part, 2 part, 3 part, or 4 part, according to the displacement more than 1 centimeter and angulation more than 45. It's good on assessed or OR planning, and some surgeon link it to the prognosis on the literatures. AO classifications, proximal humerus take number 1 and 1. It classify A, B, C. A is extra-articular 2 parts, B is extra-articular 3 parts, C is articular 4 parts. So what is the natural history if we leave the proximal humeral fracture without any treatment? We have functional consequence of mal reduction according to each element: head, greater tuberosity, lesser tuberosity, and rotator cuff. The head, if it's dislocated, we will lose all function. If the head is in varus, we will lose abduction. If the head is in valgus, it will be centrally impacted. If the head in extension, loss of forward flexion. If the head collapsed, loss of motions. Greater tuberosity, superior displacement, loss of abduction. Posterior displacement, loss of external rotation. Lesser tuberosity, if it's anterior displacement, loss of internal rotation. Rotator cuff tear, loss of motions. So what is the risk of avascular necrosis? Heretic Criteria on GSES volume 13 on 2004. He described what's called Heretic Criteria. Heretic Criteria is 3 major components: metaphyseal extension, medial hinge displacement, and fracture through anatomical neck. If the metaphyseal extension is less than 8 millimeter and medial hinge is more than 22 millimeter, and the fracture anatomical neck included on the fractures, so the combination of this factor is about 97% prediction of avascular necrosis for proximal humeral fracture. As we see here, it's the metaphyseal extension of the humeral head. It's here more than 9 millimeters, so it's good prognosis. But here is less than 8 millimeters, bad prognosis. Here is the medial hinge, it's not displaced, so it's good prognosis. Here is displaced more than 2 millimeters, so it's a bad prognosis. Now it's indication for hemiarthroplasty or reverse shoulder arthroplasty in proximal humeral fractures. It's displaced indication for the hemiarthroplasty, displaced 3 part or 4 part, age more than 70, severe osteoporosis or osteonecrosis, failure of maintain anatomical reduction of open reduction internal fixation, or head split to multiple fragment, or fracture dislocation. The same indication for reverse shoulder arthroplasty is the same like hemiarthroplasty, but we will add rotator cuff arthropathy, massive rotator cuff tear, irreparable rotator cuff, failed to reduce tuberosity fixation, or failed hemiarthroplasty and they need to revise it by reverse shoulder arthroplasty. Radiological assessment, as we know, on the fracture, the anatomy is disturbed. So templating preoperative step on fracture proximal humerus, it's major point to be taken consideration, because intraoperative you may lose all the landmarks which you search about it. You may lose tuberosities, you may lose visceral groove. So templating preoperative is mandatory on fracture proximal humerus before doing arthroplasty, to know proper size, proper height of the implant, proper retroversion or artiversion. Intraoperative position, we use beach chair with the posterior part of the shoulder is not supported. So it's a favorable position for hemiarthroplasty or shoulder arthroplasty. Approach, we use classic deltopectoral approach between deltoid and pectoralis. First step, we remove the humeral head, and we try to remove humeral head without any destruction, because we use the humeral head on both measuring the size of the head implants or the height of the implants. Second step is to identify the biceps tendon. This biceps tendon is a landmark for the bicipital groove. So before you cut it, you have to identify the bicipital groove here and landmark the bicipital groove because it's very important. And if you need to cut the biceps, you have to cut the biceps at the upper end of the pectoralis major. And now we start to staying suture for the lesser tuberosity and the greater tuberosity. Do a staying suture like that. After that, this is a special note which you will describe it later on for reduction of the tuberosity without increasing or decreasing the reduction. Now we start some tips and tricks. Here we try to separate, this is the lesser tuberosity, this is the subscapularis, this is the anterior capsule. We try to separate the anterior capsule from the subscapularis to avoid adhesion and avoid post-operative stiffness. So we make the space between the anterior capsule and subscapularis. Second tips and tricks, if we need to extend through the superior, so you have to extend through the supraspinatus and avoid to go to the rotator interval. So in some time you need to extend superior because the fragment is comminuted and you need to release some fragment. You have to extend superiorly. So extend superiorly through supraspinatus and avoid going to the rotator interval to avoid adhesion and avoid post-operative stiffness, as we see here. Go through supraspinatus, not through the rotator interval here. Version of the humeral stem. This is the aiming device of the humeral stem preparation and contains this rod. This rod, we make it with the forearm. It's directed in the same direction of the forearm. So this rod go with the forearm. And this is the indicator for the retroversion. So this is 20 to 25 degree on hemiarthroplasty. So this is the aiming device of the humeral stem preparation. And this rod inside this device is go with the forearm and the 20 to 25 degree retroversion. We avoid 2 antiversion and the 2 retroversion because both 2 antiversion or 2 retroversion, it affects tuberosity healing. So we need to be in between. We don't need to increase 2 retroversion or 2 antiversion. Some recommendation go to increase a retroversion a little bit, but not more to avoid anterior shoulder dislocation. But not more retroversion because it will affect also the tuberosity healing. Second point, we can make the retroversion with the bicipital groove. So the bicipital groove is important. So we make the lateral fin of the humeral stem posterior to the bicipital groove or make it with 20 degree. This is the humeral stem and this is the lateral fin. Make this lateral fin posterior to the bicipital groove or make angle with 20 degree. This is the second way to maintain the retroversion and to assess the retroversion. Now, establish height. A lot of indicators for establish the height intraoperatively. First one, we measure the distance from the highest point of the humeral head prosthesis with the upper border of the pectoralis major is about 506 centimeters. And if we have the posteromedial calcar is intact, we can use the native humeral head to like indicator for the height of the humeral prosthesis. Or if we have tuberosity fractures, and this is the first part with intact bone, so we can reduce the tuberosity and measure the distance from the last point with intact bone cortex to the highest point of the humeral stem. So measure this distance. And this is the height of the humeral stem. Some companies have this instrument for measure. You can put this instrument on the aiming device of the humeral stem preparation, and they measure the distance from here to the upper part of the pectoralis major, and this is indicator for the height of the humeral components. Or you can take continuous fluoro. You can take like continuous X-ray and see the stability of the joint. But take consideration that 50% laxity inferior and posterior is normal. So you put the implant, trial on each direction and the trial telescoping on continuous flow, but consideration you have to take that 50% laxity inferior and posterior is normal. So if you have this criteria, so it's stable and this height is okay. Now take some holes on the humeral, proximal humerus, anterior and posterior to the bicipital groove, and now passing the suture you are taking previously from the lesser tuberosity around the stem posterior and from the greater tuberosity around the stem anterior. The effect of head size. Large side or small side, it affects the center of rotation. It changes the center of rotation. So increase the humeral head thickness about 5 millimeter will decrease the range of motion from 20 to 30 degrees. So, and increase obligatory translation anterior and posterior in the range of motion. So 5 millimeter only increase on head size will affect the range of motion and make translation on the movement. So it will change the shoulder kinematics. So avoid oversizing and overstuffing of the humeral head prosthesis. And also we have to avoid over-reduction of the greater tuberosity because it will affect the function of the rotator cuff post-operative and it will affect the range of motion. So we have to avoid over-reduction and we have to consider what's called head tuberosity distance, which normally from 5 to 10 is normal from 5 to 10. So we have to avoid over-reduction also. Now we pass sutures from holes on lateral and anterior fin from greater tuberosity to the lesser tuberosity and from the lesser tuberosity to the greater tuberosity. And after that, we put the graft to enhance the bone healing of post-tuberosities, which is mandatory for post-operative function outcome. Now, this is a special note for tuberosity reduction to avoid over or under reduction. So this is fiber wire. Here it's clear. Go here from lesser tuberosity and go outside from through the greater tuberosity, and they come back from here and go from greater tuberosity and go out from the lesser tuberosity. So we have here two ends here, and here this side is a loop. Here I put 3 fingers inside the loop like that, and we do like a loop. Okay, again. We put 3 fingers outside and make like a loop. Okay, and put the 2 ends inside the loop like that and make tightness. And you can use one by one, one by one, one by one, to make reduction by this fiber wire. So we end with this knot, and we can use also separate knot over this one. Now we go to rehabilitation consideration. Tuberosity healing is mandatory or it's a primary concern for the post-operative rehabilitation. So tuberosity healing and tuberosity fixation is the key point of arthroplasty in shoulder on the fracture proximal humerus. So current protocol for first 6 weeks, passive supine forward flexion, passive external rotation 20 to 30 degrees, and avoid internal rotation 2 to 3 months. It will avoid stiffness and will give the patient good range of motion. So in summary, we have to avoid open through the rotator interval, and we have to release subscapularis from the capsule, which prevent adhesion and prevent post-operative stiffness. Avoid excessive retroversion, as we mentioned before, because it will affect the tuberosity healing. Restore head thickness and height. Templating of the native head is important because, as we mentioned on the fractures, we lost a lot of anatomy intraoperative, so templating is mandatory. Avoid overstuffing. Avoid over reduction of the tuberosity, and also appropriate tuberosity position from 6 to millimeter. And thank you.
Thank you very much, Dr. Hani. The next presentation will be with Dr. Mahmoud Hafiz, the use of PSI for glenoid and humeral component positioning in shoulder arthroplasty.
Thank you so much for inviting me. I'm actually new to shoulder surgeons because my specialty is hip and knee arthroplasty. But I'm going to talk about my experience in PSI and how I managed to transfer this with the help of Dr. Bassem Flega to the shoulder surgery. This presentation and the experience actually was gained from 3 centers that I worked on abroad, starting with my experience in UK, especially at Leeds University, where I did my MD and I developed the PSI starting from 2001, and then working in Pittsburgh in US and Toronto University, and then back to Egypt here at October 6 University, where I'm working now. So this is a collective experience now from these 4 centers where I'm going to present. Initially, robotics came first as a computer-assisted tool before the PSI. And this is amazing because robotics in orthopedics started in 1992, actually published in 1992, which means that it was used in 80s. In 1992, the first paper appeared in Clinical Orthopedics, and related research was using a robot for hip replacement. And what's strange about here is that you're starting with the most complex technology and then moving from robotics to navigation, which is less complex than robotics. In 1999, started the navigation, and actually I attended the first symposium where they had a live surgery for knee replacement by navigation in Tuttlingen in Germany, and this was the first when the first navigation appeared to be used in orthopedics, at least for knee replacement, because it was used before for neurosurgery and spine. So moving from the complex to the easier and user-friendly is the PSI. Which came, I started in 2001, but actually it became in practice in 2008. And the reason for that is that something called 3D printing machines. The one on the left-hand side is a rapid prototyping machine. This is the name for it. And this is a complex, very expensive. It's equal to probably 500,000 sterling pounds. The one on the right side is a desktop machine, which came into use in the last 7 or 8 years, and this becoming now 500 pounds rather than 500,000 pounds. So it's 1,000 pounds less, 1,000 times less. Okay, so what this 3D printing could do for us in surgery, including shoulder surgery, they could print a model. So if you have a complex shoulder where you have bone defects, problems, or tumors or whatever, you can print just only the scan. Or you can design a guide that can help you in positioning glenoid component or making the cut in the humerus. Also, you can design an implant like special plate and screws like what we use in maxillofacial. And at last, you can print like a custom-made implant or even a graft. You can see here like a tumor in the mandible. Half of the mandible could be removed, and then you can have an artificial material printed by the 3D based on the CT scan or MRI of the opposite side. So one slide about the history. When I started the patient-specific, I called it at the time patient-specific templating. It was a novel technique where I replaced the complete instrumentation system of the knee to be only 2 pieces. And this was published in Clinical Orthopedic Related Research in 2006. Where I presented 45 experimental total knee replacement. We did not have any equipments like robots or navigation, just only a specific software on a PC and the design, the jigs, and the 3D printing. So with this amazing technology, how you can replace all these amount of instruments and also do the planning so that you don't require to enter the medullary canal. So how did we transfer this into shoulder? Actually, we have a problem in Egypt here is that sometimes the stock of the implants could be missing. And we face this almost every time with hips and knees that some of the sizes could be missing. So when we have a planning and we know the sizes beforehand, it makes it great. And this is something that Dr. Bassem Flega is also interested in sorting out this by having the planning at the start so that he knows that everything is available beforehand. So the collaboration with Dr. Bassem Flega started several years ago. He gave me the parameters for the design that required to be done for the humerus and for the glenoid. And our team worked on this and developed the guides for the humerus and for the glenoid. However, we are not the first to develop PSI for the shoulder because Professor Ainati from Cleveland Clinic, they developed this first and they published this, or also they have patents for it. And also other companies, implant companies, they develop the PSI. So with the PSI, basically what we do is just we do a CT scan of the shoulder. You have the humerus, you have the glenoid and scapula, and then you can make planning for the surgery and simulation, measures the sizes, design the guides that's going to sit on the glenoid and the humerus, and eventually print these guides to have it as a physical models that could be sterilized and used during surgery. So this is a design of the glenoid. You can have it according to the companies. So if we know the company beforehand, then we design the component, the guide according to the shape of the component. This is the one for the humerus. Our humerus guide actually is unique because there isn't, at the time when we developed the humerus, there was no other companies that has good humeral guide for shoulder replacement. We were the first and we have patent for this. So we have the shoulder here. There are several designs in the market with many other implant companies. I'm not going to go through this, but just only this is one of these examples. This is what we do for the knee. I'm going to skip this one. I mentioned about using the 3D printing for designing patient-specific implants. Also, you can use it to design a patient-specific spacer, whether you have an infection or you have a tumor like this case, then you can design a guide where it can help you where you get your cut with the safety margin and you know where is the level of the tumor. And after you do the cut, then you can use the spacer, which is patient-specific, preparing for the second stage when you need to use a patient-specific implant or you use a tumor implant. Here is a case with a fracture that required anatomical total shoulder replacement. This is the planning with the sizes. Here you get many screenshots that you give to the surgeon for the bone and the dimensions. And these are in different planes. As you can see here. So you can have as many screenshots as you want, which will help you during surgery, especially when you have extensive osteophytes or bone defects, then you know where these are placed. And also you can assess the quality of the bone. So by doing a finite element analysis, you can know where the bone which can get the pegs or was it required reaming or not. Here is a humeral guide. This is a second case was a total shoulder replacement for a patient who had a fracture fixed by plates and screws and then developed osteoarthritis. During this planning, you can see the dimensions of the bone and also the glenoid and the distance for reaming. And this is very important because not every glenoid has got a good bone stock. So some of them may require very minimal reaming or no little reaming. And that's important to identify this beforehand. Here are the dimensions. This is the design. And this photograph for another case, which was done by Dr. Bassem Flega, where the humeral guide is positioned, and then you can make the cut on the top of this guide, and then you can maintain the required inclination of the cut in the coronal and sagittal planes. This is a very interesting case which was done by our team in October 6 University Hospital, where we had this patient with a fractured glenoid, which had malunion and the defect and the deformity, as you can see here. So you can see the defect here is really massive. And then you have the glenoid lost its normal configuration. So it is not a cavity anymore. And you have two surfaces here. So it's very difficult to do this when you go for surgery, because you wouldn't be able to know where you position the peg and on which surface you lean. So unless you know which part is the normal anatomy and which part is the normal one, that's very difficult. So you can notice at ease when you do the planning while the patient sitting at home, but you do the planning on the computer, and then you can design the guide that's going to help you to position. And this is a guide in place with the surgery done. Thank you so much. I look forward to your questions.
Thank you very much, Hafiz, for this very elegant presentation. The following presentation will be with Dr. Oliver Verbach, will be on glenoid retroversion. What is the limit for anatomical total shoulder arthroplasty?
Okay, good evening, everybody. Can you allow me to share my screen, please?
Yes.
Yeah, perfect. Okay, so thank you again for the invitation on this interesting topic. And I would like to focus a little bit more on where the limit is for anatomical shoulder arthroplasty in terms of retroversion of the glenoid. So I think we all know that the glenoid component is the limiting factor to the success of total shoulder arthroplasty. This is related to the technique. Surgical implantation is not always the easiest part, and also the mid and long-term survival are determined by the glenoid. Especially type B glenoids are challenging because there's only so much bone that you can correct or ream. The correction of the limited is by bone stock and also by subluxation. And therefore, we see, among others, that people are doing more and more reversed arthroplasties, even in patients with the primary osteoarthritis and an intact rotator cuff. Other possibilities than reverse arthroplasty, newer possibilities now are coming our way with augmented anatomical glenoid components, and I will talk about that a little bit later in the end of my presentation. I'm still a big fan of anatomical arthroplasty. I must say that's still my practice. This is 2019. This is the year before the Corona year. Is still about 70% reverse and about still 30% anatomical, and I still believe it has a very important place in my practice. But of course, the glenoid version of the correction of this is limited because by the bone stock, and there's been previous reports that the maximum correction done by eccentric reaming, which basically is reaming the high sides, is about 15 degrees. If you correct more, obviously you will end up with no bone stock at all, and this will have a bad influence on the implant fixation, but also on the tension of the rotator cuff. On the other hand, as well, if we do this using standard instrumentation, if you look at our precision, it looks like we're not always that good as we think we are. This is a landmark paper from Dr. Ianotti's group in 2012, where they compared standard instrumentation with PSI instrumentation, and actually retroversion is not so reliable. Correction of retroversion is not so reliable using standard instrumentation, especially when the retroversion is more than 15 degrees. And this was the start for 3D planning and PSI, like the previous surgeon was alluding to. This is a patient that we all would agree is quite a challenge. In terms of indication, he's a 52-year-old. He's clearly young. He has a primary osteoarthritis, but a deformed glenoid, a B3 glenoid. As you can see, the cuff is intact. And preferably, you would do an anatomical replacement. But the question here is it actually possible? And if we look at the glenoid and the retroversion, for me, the 3D planner has really changed my way of looking at it and has changed my practice quite a bit. I use the planning tool to virtually assess whether I can still correct some part of the retroversion without compromising too much bone stock and compromising my implant fixation and trying to avoid PEG or cement perforation. And this is how I try to do my surgery in a virtual fashion. And if I think it's still doable, I will use PSI guides to actually execute that virtual plan. I have a guide that helps me to find the first central pin, and this is obviously going to determine the further preparation of the glenoid and the implantation of the glenoid component. And then I have a second reamer that helps me to exactly execute the eccentric reaming so that I can get the correction that I desired to get. And then finally, I'm still able to do this implantation of this anatomical glenoid component, and all cemented in this case. And this is that patient, and in the meanwhile, he had 2 of these type of surgeries done, a bilateral, and as you can see, this is 2 years after his surgery. He has an excellent result. I'm very happy with that. Anatomical replacement gives that sort of results if you do them well, and at least because he's still young, he has a future much longer than I think for a reverse arthroplasty. So we're using this technique, and this is my experience. 22 patients. We looked at these prospective study. We just published them in JSCS in seminars in arthroplasty, where we did this technique. And as you can see, the mean preoperative version was on an average 15 degrees. So I agree that if it's more than 20, 25, obviously there's a problem. And as you can see as well, the correction was on average -7 degrees. So we do not try to correct all the way to neutral. It does not make any sense to try to correct an anatomical glenoid to 0 degrees if that is this patient had a constitutional retroversion of 15 degrees, because that also will not work. So we try to find a sort of way in between. But we had very good outcome, both clinical as well as radiological outcome. The biggest concern, of course, is glenoid medialization. How much bone do you remove? And we found a clear linear correlation between the correction of the version and the medialization. And basically, we found that we, for 1 degree of correction, we would take away 0.8 millimeter of bone. And on average, in this study, that meant that we removed about 6 millimeters on the anterior side. This is another example of such a patient with a preoperative version of 16 degrees that we corrected to about 7.8 degrees. So not to neutral, but somewhere below 10 degrees. This is that result for this patient. The digital planning and the virtual planning helps me to finally make the decision preoperatively. This is a patient, as you can see, where when we correct for the retroversion, we really need to medialize quite a bit. And in this case, I think this is 1 bridge too far. This is more than 10 millimeters of medialization. This is obviously not good for the implant fixation, and also not for the tension of the rotator cuff. And so therefore, probably this patient does better with a glenoid, with a reverse type of glenoid implantation. Again, here, we also want to correct the version using an augment, a posterior augment in this case, which leads to a nice correction of the retroversion in this type of surgery for reverse, I think it's important to try to correct to 0 degrees. And here we have this final virtual result. So my personal algorithm for this problem is if I can correct the Glenoid version to less than 10 degrees of retroversion with eccentric reaming and less than 80% posterior subluxation, my preferable technique is eccentric reaming and standard anatomical glenoid components. If it's not correctable to less than 10 degrees, but the posterior subluxation is still less than 80%, I will use an augmented anatomical glenoid component. And if that is not the case, whether it's not correctable to less than 10 degrees or the posterior subluxation is more than 80%, I will definitely use a reverse arthroplasty with or without bone graft or an augmented base plate. So please save the date for an interesting, hopefully live conference that we are organizing here in Antwerp next year in April, specifically focused on shoulder arthroplasty and innovation and new technology. Thank you very much.
Thank you very much, Dr. Oliver. The next presentation will be with Dr. McFarland. Outcomes after shoulder replacement, comparison between reverse and anatomical total shoulder arthroplasty.
Hello, and thank you for this great opportunity to speak to your group. And I'd like to recognize my fellows who contributed to this talk. It's going to be about the expanded indications for reverse prosthesis, but also our experience here at Johns Hopkins with reverse total shoulder arthroplasty. These are my disclosures. I am a consultant for Stryker Corporation, but I really don't have any of their implants in this talk. The goals are to understand the wider group of indications for reverse total shoulder arthroplasty and also my experience and philosophy of use for reverse total shoulder arthroplasty. It was designed primarily for cuff tear arthropathy. This is a fairly classic acetabulization of the shoulder joint due to a torn rotator cuff with superior subluxation, pain and loss of function, as you see in this individual with superior subluxation. It was first approved in the United States in 2004, but it was approved for only cuff tear arthropathy. First, the systems available in the United States were by DePuy and Tournier, and now there are, of course, about 25 or more systems available in the market. So the market is significantly increased in the recent past. The earliest literature was by Dr. Walsh. It was a multi-center study, and these were sort of the initial results that were quite excellent. They did have some failures at the first year mark with infection dislocation as the primary causes, but they had concerns that after 8 years, patients complained of pain and weakness. So they did caution about the long-term results and initially said that this operation shouldn't be done on patients under the age of 70 years of age. That, however, has changed quite a bit. Reverse shoulder arthroplasty is now the most common arthroplasty inserted over total shoulder arthroplasty, not only in many programs, but in many countries. The indications have expanded for conditions that in the past we had no previous good solution, and this includes not only patients with rotator cuff tears, but with bone loss and many other conditions. So this is our experience at Hopkins. These are our inotopic arthroplasties that were performed since I started around 1995, and you can see that they slowly tailed off around 2017. This is the experience going up through 2017, and you can see that the majority of the prostheses are almost now reverse arthroplasty. So the best indication for reverse arthroplasty is pain. This is a pain-relieving operation. We tell people that the goal is to regain the motion as much as possible, but we consider a good result the ability to reach the top of your head without pain and improvement in your ADLs. There are some precautions, however. You want to avoid young patients who sometimes do things like this where they have accidents and fracture their shoulder. You don't want a non-compliant patient, patients who fall frequently or have seizures, and also avid sports participants who tend to fall and break their arm or their prosthesis around the arm. Here's a good example of a cuff tear arthropathy. I showed this earlier. This gentleman has very poor range of motion. You can see that he's had a previous operation there. This is him post-operatively, very happy, has no pain. This prosthesis was an early DJO prosthesis that's cemented. Don't any longer cement stems, but they do quite well without cement. You can use it for people who have rotator cuff arthropathy after failed rotator cuff surgery. This woman went on to have a pretty good result. Unfortunately, she has a little bit of pain because she fell prior to this video, but she is actually quite happy. Osteoarthritis with rotator cuff tears. This patient has severe osteoarthritis, but she has a small rotator cuff tear. Rather than fix it, we went ahead and did a reverse total shoulder arthroplasty. I should add that she's our oldest patient to date. She's 95 years of age. This is her result. Not too shabby. I take that any day. The other indication is osteoarthritis with glenoid bone loss. This is a large group now. This gentleman has a very thin rotator cuff, but it's not torn. But he does have significant glenoid bone loss and medialization and posterior wear. Here he is with his prosthesis, and some of these patients are the happiest. In our experience with glenoid bone loss, we reported 2-year follow-up on 42 patients with a variety of different glenoids. When you reclassify these, most are B3 type glenoids with only one type C. So the classification has changed a little bit, but we did just recently report this month, in fact, in JBJS, our 5-year results on this cohort of patients. We had scapular models made using CT scan on all the patients, so we had a good idea of what their glenoid really looked like. We did eccentric reaming only. I was initially very worried about medialization with reaming them flat, but we now use modeling to know exactly how much bone we have to take off to make it flat. With a minimum of 5-year follow-up, we had 2 base plate failures, which is around 5%. One was a type A2 glenoid and one was a type C glenoid. About 19% had notching, not only at 2-year, but at 5-year follow-up. And at both time frames, all patients in both groups were happy with their result. One way, though, that we should think about this study is that we used only one device, which was a screw-in type base plate with central fixation. Did have peripheral fixed screws or locking screws. The amount of bone was defined by coverage on the base plate, which we set at around 80%. So we don't have great significant bone loss in these patients, but I'll show you our solution for that later. You can also use this for immunologic arthritis now. This is a patient with severe rheumatoid arthritis. This is her result. She's very happy. She has great range of motion and no pain. You can also use it for patients who have a failed hemiarthroplasty. This gentleman had so much pain he wouldn't even lift his arm. You can see that he has eccentric wear superiorly and central wear medially. Here he is with the result. This is what you want. You want a happy patient and who has good motion and good function. This is a gentleman who had about 7 previous operations. He too had a failed total shoulder arthroplasty, which had been removed in terms of the glenoid component, but he also had brachial plexus explorations. He had very little motor function, and we did a reverse on him, and here's his motion. He's a retired plastic surgeon, by the way. and you can see all the debris from previous operations, but he's done extremely well. They're also very good for acute proximal humerus fractures. These are oftentimes 4 parts, but sometimes the head is split and there's just more parts than you can count. This is a woman who had a proximal humerus fractures. She doesn't have great range of motion, but she is very happy because she has no pain with motion, which is probably the major advantage of a reverse over hemiarthroplasty or internal fixation. This woman had a malunited proximal humerus fracture. She was handicapped, however, by having poor external rotation. I don't really use latissimus dorsi transfers because I think the results are somewhat unpredictable. Other authors and surgeons have better results, I think. But as a result, with her surgery, she was pain-free, but she did have still some limited range of motion. We've had several patients who have fixed dislocations, usually anterior. They get significant anterior glenoid bone loss. This is a gentleman who's in his early 30s who had a glenoid fracture that had malunited, and basically this was the only solution, and he's had fantastic motion even at 5 years follow-up. You can use it for all sorts of dysplasias. Here at Hopkins, we have a large genetics group, so we see all sorts of different abnormalities. This is a woman with a kind of dysplasia. These are her results after surgery. She actually is pain-free, believe it or not, but her motion was not significantly improved. So there are limits to what this operation will do for her. There are also lots of reports about using it for tumors. Our oncologists use it as well. And I've been involved in a couple of their cases, but by and large, they're fairly self-sufficient. The youngest patient in our series is this gentleman who's in his early 20s. He had multiple operations for recurrent posterior dislocations from seizures. This is his result. He's got great range of motion. We do have 8-year follow-up on this gentleman. He's had no problems thus far. So why not use this all the time? The complication rates can be as high as 70%, but that's usually in the early studies. Longest term follow-up shows survival around 90%. Could it be the next metal-on-metal hip and a disaster? We really don't know. There are some bad results like this. Most common complication is notching. It's worse with or associated with poor results. Again, we don't know if this is a time bomb going to go off sometime in the future. The latest thing, though, is custom glenoid components. We use it for patients with very severe glenoid bone loss. They usually have too much bone loss even for effective bone grafting. I'm not very fond of bone grafting around the glenoid anyway. Basically what we do is get a CT scan and we trial it to see if we can get a good fit. And then we create a trial. We then make the reel. And this whole process takes about 2 to 3 months. Implantation can be somewhat tricky, but the long-term results have been pretty good so far, but they're not extensive. One problem with this is that the implants are fairly expensive. So in conclusion, there have been expanding indications for the use of reverse total shoulder arthroplasty. Long-term results have been promising. I personally think that for a majority of cases, you can use eccentric reaming. For those who have significant bone loss, then I favor a custom implant right now. The future is yet to be known in terms of how they do, but I think this is a good algorithm and what we use in our practice. Thank you very much, and look forward to any questions.
Thank you very much, Dr. McFarland. Now we're going to answer some of the questions. We'll begin with the first presentation. Dr. Hassan Ali, you have a question here. What is your choice if a patient has rheumatoid arthritis? Is it anatomical, reversed, or hemarthroplasty?
Can you hear me?
Yes.
I'm sorry, I didn't quite get the question.
The question, in cases of rheumatoid arthritis, is there a certain type of replacement which you prefer? Is it anatomical or reverse or hemarthroplasty? This is the question.
Well, it's a great question. Nobody really knows how rheumatoid patients are going to do, but many of them get rotator cuff pathology or start with rotator cuff pathology. And so if there's, again, age is probably related as well, but I tend to, in rheumatoids, put in reverses because they so commonly get rotator cuff tears over time with or without an implant. So by and large, I would say a majority of my rheumatoids I put in reverses these days.
Okay, thank you. Dr. Hassan Ali, do you have any comments?
Yes. I mentioned in the presentation, if the rotator cuff is intact or there is no major tear, I would try anatomical total shoulder arthroplasty and according to the age of the patient. If it is between 50 to 60, anatomical is okay. After 70, reverse is okay.
Dr. Andir?
Yes, I think it's the same answer like Dr. Hassan. If with intact cuff, I would go for a total shoulder. And if the cuff is torn, I would go for reverse.
Dr. Hani, have any comments? The voice. We can't hear you.
Yes, I think it's a standard answers. It's according to the rotator cuff conditions. If it's okay, it will good better and the good functional outcome. If it's bad, it will poor functional outcome.
Dr. Mahmoud Hafiz, do you want to share in answering this question?
No, this one's passed.
Okay. Dr. Oliver Burbach?
I'm a little bit more towards what Dr. McFarland says. I think the rotator cuff sooner or later will tear. So if the patient is, let's say, above 60, I would probably go primary for reverse. If he's younger, though, I may still do an anatomic and use a convertible stem, so that when there's a revision needed, possibly it could be an easier procedure.
Dr. Bassem Flick has a question to raise here. You want to go Dr. Bassem, are you with us? Dr. Bassem? Okay, Dr. Bassem has sent a question about the use of bone grafts to correct the defect. What are the indications and the different techniques of bone grafts? So we can begin answering. Dr. Bassem, do you want to ask this question? Do you want to lead this discussion? Go ahead.
Actually, it's better. I'm sorry because I am in the late stage of Corona and I still have a little bit cough. So I will only cough. So yes, that's the question. I want to ask good evening to all of you again. And nice to see you finally, Dr. McFarland. Thank you, Dr. Farabond and all others, Dr. Hassan, Dr. Mahmoud, Dr. Ahmed Andil, and Dr. Hani. Yes, the question was for was in case of glenoid problem. Dr. Oliver mentioned the reaming of the glenoid as a solution. So my question is, how do you compensate the indirect lengthening of a rotator cuff? Do you put then a larger head to compensate that distance, or you make a reefing to the rotator cuff? Because I think when you medialize the glenoid, you will have more space in the joint.
Yeah, so that's definitely a concern. That's why I think there's a certain limit to eccentric reaming. And so the study that we published, the average was about 6 millimeter, and this is eccentric reaming, so it means on the anterior side. And I think in that case, really it does not affect too much the joint tension. These patients are young, arthritic, primary osteoarthritis, and so the soft tissues are contracted anyway. So if you not medialize too much, I think it does not affect too much the stability. But that being said, it is a concern, and of course you need to test it with your trial components in place. And if it's unstable, there's a problem. It's difficult to solve. Larger humeral head usually does not really work because it's conflicting with the cuff. The only thing you can play with a little bit is the offset of the humeral head in larger diameters. For me, plication of the cuff, posterior capsule plication, has not worked very, very well. So if I really am concerned about stability, I rather go for an augmented component, anatomic component, to not take away too much bone or even do a reverse.
We have a question here about the capsule. During your surgery, Dr. Hani and Dr. Andil were mentioning that we should respect the capsule and try to reconstruct it or to have it close to our joint away from the muscles to have a better outcome during rehabilitation. So we want to have the experience of our guests about this point.
From the previous question, I need to mention something regarding the change center of rotation on anatomical total shoulder or even reverse shoulder arthroplasty, which makes some medialization. I see some patient complaining of empty shoulder. He complain only from empty shoulder and not complain from the range of motion or even the functional outcome. He just only mentions that his shoulder is become empty. When we make a medialization and reverse the shoulder or even some medialization on glenoid loss. So I think some consideration about this one to start a little bit lateralization of the glenoid or lateralization of the reverse shoulder. And I use, I know I think it's a standard technique. I use the humeral head and take some chips, make it like a circle, put it under the base plate. Because nowadays we know all that the reverse shoulder, we use the standard 25. In the past we used 28, but I think now all recommendation is go to base plate 25. And I think also on the humeral stem, we have to use offset humeral stem. Because it gives also some of increasing the range of motion of some patient. Regarding the capsule, I think I use it as a standard techniques on my previous cases to open the space between the subscapularis and the anterior capsule, make like a plane on this area. Because I am talking about the fractures, because if we leave it, it have some adhesions and it will affect the post-operative rehabilitation. So we can make some release between the anterior capsule and the subscapularis and make this plane which I show in my presentation to decrease the adhesions between the capsule and subscap, which limits the external rotation of the patient post-operatively. And I see different really between cases with standard release of the capsule from the subscapularis and the patient which I didn't do this step. So I think it's, on my experience, it's an important step on the fractures of proximal humerus with arthroplasty. Thank you.
Hassan, Ali, do you have the same experience? Do you have any comments on this? Dr. Hassan? We can't hear you.
No comment, Professor.
Okay. Dr. Andil?
Yeah, for me, actually, in all cases of arthroplasty, I do resection of the capsule. I mean, I have to remove the capsule to for better exposure of the glenoid and etc. And also to avoid adhesions later on that may affect the range of motion of the patient. So I routinely, when I do arthroplasty, I look for the medial glenohumeral ligament and the inferior glenohumeral ligament, and I do resect them with the capsule. So that's what I do routinely.
Dr. Oliver?
Sorry, I missed the question. Sorry again.
The question, what do you do for your capsule during surgery of total shoulder arthroplasty?
For the anterior capsule. Yeah, I resect it because I think it limits the passive external rotation. Sorry, I was answering one of the questions in the chat. Sorry.
Okay. Dr. McFarland?
The same. I'll sometimes resect it if it's very tight, but certainly release it around the glenoid rim. So pretty much the same as everyone else.
Okay. We have a question here about the early complications after shoulder replacement. We are talking about late complications like loosening and but what are the early complications and their incidence? We can begin with Dr. McFarland.
Well, the infection rate is around less than 1%. The nerve injury rate actually is around 4 or 5%, but almost all of them are neuropraxias, so that's pretty good. The base plate loosening rate is around 1% or so these days, 1.5%. Interesting enough, acromial fractures are around 3 to 4% in some studies and as high as 8%. Instability, these days instability is less of a problem than in the year, the 2000s, because people are using a more vertical head neck humeral tray. So the instability rates now are down around a couple of percent. So the overall rate is around 8%, 8 to 10%. Interesting, the group from EGSSSA, I think in this month's JSES, I'm not sure, they have an article comparing the complications of total shoulder and reverse total shoulder and at 2 years, and I think they're about the same. So fortunately, even though there are lots of complications and the overall rate is actually higher than I would expect, but they're about the same in the two different procedures. So it's a pretty interesting study.
Dr. Oliver?
Yeah, nothing really to add. Same thing.
Okay, anyone who wants to add anything for this point?
Could I have a question?
Yes,
Yeah, my question to our guest international speakers, Dr. Verborg and Dr. McFarland. Probably you have seen more cases of failed reverse shoulder and also failed revision, where the glenoid really damaged but almost done. I don't know what is going to be in future. I mean, as I mentioned, I'm a hip and knee surgeon. I have experience doing like revision hip replacement for a patient who had 4 successful hip replacement before. So I did the 5th one, not infected, it's good. Patient is 80 plus, and still there is some little bone in the acetabulum that you could manage with. How about the situation in the glenoid? And what is the strategy in future? Because the future is going to be even worse. I heard that it became mandatory to use computer-assisted technology, especially PSI, for such cases to protect yourself, especially for from medical legal point of view or any litigation. So I like to hear your comments on this.
Dr. Verborg doesn't mind, I'll go first. I think, fortunately, really massive bone loss where you can't do anything is pretty unusual. I have probably 2 or 3 patients, though, whose glenoid was destroyed to the degree that there really wasn't even a way to put in a custom component. One of the beauties of these custom components is that they can really deal with fairly significant bone loss. And admittedly, the follow-up is short, but I think that they're going to really be the solution for significant bone loss. The thing that's interesting is that probably not only reverses, but just total shoulder arthroplasties, when the glenoid gets loose, it sort of vibrates in the vault. And some of the worst bone loss I've seen in my practice in revision cases is actually from cemented glenoid components that got loose and destroyed the glenoid. So, one of the concerns with reaming or eccentric reaming with reverses is that it leads to significant bone loss. Well, you can get significant bone loss with just an anatomic glenoid that fails. So as I mentioned, my algorithm, I don't really like to bone graft around the shoulder. I think it's very difficult to do. It's also, I think the results of the studies are, all of them are short-term follow-up. We don't have many that really substantially show great advantage because the bone grafts, I think a lot of them fail. The beauty of these custom components is that you can customize the screws to where there's adequate bone. And again, we don't have long-term follow-up, but I think it's so much easier to put these things in than to try to bone graft and sort of hope that it heals. So, or that bone graft heals. So it's really very predictable so far, pretty predictable implant group, the custom implant. So I try not to bone graft if I can help it.
Yeah, similar experience here. I do not see a lot of indications really to use custom-made implants. I do agree that an anatomic glenoid, when it gets loose, you better hurry up because it can really end up with a completely destroyed glenoid. So, and that's sometimes a problem because the patients tend to do quite well before they really end up in your clinic. Asymptomatic loosening seems to be fairly common. And so once they're painful, I always warn my patients that have an anatomical replacements to come back and see us at least once a year for follow-up, because I think it's important. I must say that my experience with bone graft is not so bad, but I think this is the less severe bone loss, where I use the humeral head graft as a graft in primary cases in combination with a trabecular metal peg. But this is for, let's say, manageable glenoid defects. I'm also using now a little bit more of augments in base plates. Well, obviously also works well and probably make it easier. You're not so depending on the healing of the grafts, but I think Pascal Boileau learned us how to use grafts and in his bio-RSA technique, and I think it's still an option in some cases. So, but there is a limit. There's definitely a limit. I think if you need a graft more than 10 millimeter thickness, there's a problem. And also, which also is important, is that your glenoid component has to seat at least 50% in the native glenoids. If that's not the case, it's impossible. If your graft is if your peg is more than 50% in the graft, it's likely to fail.
Very good.
Thanks.
By this, we have ended our webinar. I want to thank our guests, Dr. Oliver Verbach, Dr. Edward McFarland, Dr. Mahmoud Hafiz, Dr. Hani Saeed, Dr. Hassan Ali, Dr. Bassem Fleger, Dr. Andine. I just want to announce our coming webinar, which will be in the 7th of May on arthroscopic treatment of proximal fractures. All of our friends are invited to this webinar, and it will be at the same platform of questions and international guests with us. I hope that you can join us in the coming webinar. Now there will be a video for the company which sponsored this webinar, Pfizer, Vitreous, which is a video presentation. Thank you very much.
Thank you.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.